Okay, so some more obstetrics coming at you. Let's get into labor. So the first thing we want to talk about is cesarean sections. These count approximately for 1/3. Let's get this line back up here. They count approximately for 1/3 of U.S. deliveries and are on the rise. The most common incision for a cesarean section is low transverse, but a classic vertical incision allows more space to remove a fetus in a horizontal position. Now, there is a greater risk of uterine rupture with the classic incision and a vaginal birth after the cesarean or the VBAC should not be attempted. Okay? That's what that means right there. The maternal risk of mortality and morbidity is higher with a cesarean section than a vaginal delivery. So why does so many doctors, lawyers, women that know this keep getting cesarean sections instead of having vaginal delivery then? Well, they can time it up. They can get it at the exact time they want it, and it's more convenient for them. So even though the risk is there, the risk reward benefit kind of thing. Anyways, risks to the mother include anesthetic complications like hemorrhage, infection, wound adhesions, bowel injury, and an increased risk for what? For DVT, deep vein thrombosis. Additionally, the recovery time is increased for the mother. Now, the most common indication for cesarean section is what? Is a prior cesarean section. That is the most common indication for a cesarean section, is a prior one. The most common indication for a primary C-section is failure of labor to progress due to one of the following: hydrocephalic or cephalopelvic disproportion, where the fetus is too big and or the pelvis is too small. I'll write that in there for you. And contractions are not powerful enough despite oxytocin administration and rupture of membranes. So, the two most common indications for a primary C-section is failure of labor to progress due to one of the following: cephalopelvic disproportion, where the fetus is too big or the pelvis is too small, and or number two, contractions are not powerful enough despite oxytocin administration and the rupture of membranes. Now, a summary of indications mentioned include breech presentation, placenta previa, vasoprevia, placenta abruption, active herpes, untreated HIV, non-reassuring fetal testing, umbilical cord prolapse, and multiple gestations, which is a non-vertex twins or higher order multiples. All of these things right here can be ideal for a C-section to occur and to happen. So That is cesarean sections and about the basis you can be tested on them. So let's talk about fetal heart rate monitoring. Now this is important. So fetal heart rate monitoring can be achieved with an external transducer placed on the uterine fundus and or within an internal device placed on the fetal scalp. Now fetal bradycardia is diagnosed when the fetal heart rate is less than 110. Less than 110 beats a minute. That is fetal bradycardia. Now, non-hypoxic explanations include maternal beta blockers, local anesthetics, and congenital heart block. Now, fetal tachycardia is when it is greater than 160. Explanations include beta agonist, fever, prematurity, and fetal movement. Normal fetal heart rate monitoring is very reassuring that the fetus is doing well and on their way. A reassuring fetal heart rate tracing has a baseline heart rate between 110 and 160. 110 and 160. No decels. I'll explain what that is here in a minute. No decels. Positive accelerations. Positive accelerations and variability. Alright, so a non-reassuring fetal heart rate tracing has unexplained bradycardia or tachycardia, no accelerations, repetitive variable decelerations. That's not good. Any late decel. And no variability. No variability. That's a non-reassuring fetal heart rate tracing. Now, the fetal heart rate tracing should be used in conjunction with the tachometer. With the tachometer, right here. With the tachometer reading to classify decelerations. To classify decelerations, and that's what we've been talking about when I was talking about up here, no accelerations or no decels. So let's start with early decelerations. This is the easiest one to remember. An early deceleration is a mirror contraction. A mirror contraction. They are a result of vaginal or vagal stimulation from the fetal head compression with contractions. So this is where OMM comes in. They are not worrisome. It's just the fetal head being banged and the vagal nerve being stimulated. That's all early decels are. They're not worrisome. Now, variable decels, those are sudden drops in fetal heart rate. Sudden drops in fetal heart rate with variable relation to contractions. So they are not, or they are the result of umbilical cord compression and may indicate fetal acidosis. That is important to remember if you don't remember anything. Fetal acidosis with variable decels. Early decels are not a bad thing. They're just mirror contractions. being pressed on by the head by the vagus nerve. Variable D cells, think fetal acidosis. And late D cells are the most worrying. There is a gradual decrease in FHR. There's a gradual decrease in FHR, fetal heart rate, delayed in relation to what? See if you've understood what we've been talking about this whole time. To the contraction. Very good. To the contraction. There's a gradual decrease in fetal heart rate and delayed in relation to the mother's contraction. They occur in response to uteroplacental insufficiency. Uteroplacental insufficiency and may also indicate a fetal acidosis. Fetal acidosis. So late D cells are bad. Now, a non-reassuring FHR tracing should first be managed with conservative resuscitation attempts. Management of a non-reassuring FHR tracing would be like turn off the oxytocin, give normal saline bolus, administer high-flow O2, remove the mother from the supine position and place on the side to minimize the IVC compression, rule out prolapsed umbilical cord with vaginal examination, and amniofusion may help alleviate variable D cells due to cord compression, etc., etc. So you just go on with that. That's how you manage a non-reassuring fetal heart rate tracing. If the above resuscitation attempts that I just described are not successful in normalizing the fetal monitoring strip, and fetal hypoxia is the probable cause, the fetus must be done what? Delivered immediately, right? If the woman is in stage 1 of labor, this must be done via a cesarean section. If in stage 2, an operative vaginal delivery or cesarean section may be performed. So that is fetal heart rate monitoring. There's a lot of information, I know. So normal labor, let's see if we can make it a little easier for you. Normal labor. So normal labor, the 3 P's affect the length of the active phase of labor. That is power, passenger. I'll explain what these mean in a second. Power, passenger, and pelvis. The 3 P's. The power is the strength and frequency of the contractions. The passenger is the size and the position of the neonate. And the pelvis is the size and shape of the mother's pelvis. So, that takes us into the first stage of labor. That includes the latent phase and the active phase. Now, the latent phase begins with the onset of contractions resulting in cervical dilation or effacement, or you could also call that thinning. Effacement, thinning, or dilation. You'd be surprised how many people don't know that. So there you go. The latent phase begins with the onset of contractions resulting in cervical dilation or effacement, which is thinning. So you see cervical change in the latent phase is slow and ends when the woman is 3 to 4 centimeters dilated. 3 to 4 centimeters dilated is when the latent phase is ended. Now, the active phase follows the latent phase and proceeds until the woman is 10 centimeters dilated. So from 3 to 4 to 10, that is your active phase. And the cervical change occurs more quickly in the active phase. It should be at least 1 centimeter an hour. 1 centimeter an hour in the nulliparous woman and 1.2 centimeters an hour in the multiparous woman. Now, that's just the first stage of labor. All those dang numbers to remember. The second stage of labor is from the time of complete dilation to the time of delivery. So you can have a prolonged stage 2, and stage 2 should be less than 2 hours in a nulliparous woman without an epidural, or less than 3 hours in a nulliparous woman with an epidural. All right, and in a multiparous woman, it should be less than 1 hour. This is stage 2, less than 1 hour in a multiparous woman without an epidural. And if she had an epidural in the multiparous woman, it should be less than 2 hours. In the case of a prolonged second stage, maternal exhaustion or fetal distress, and operative vaginal delivery may be indicated. This includes forceps delivery and or vacuum-assisted delivery. Now, vacuum-assisted deliveries are associated with high-risk cephalomatomas and shoulder dystocias. That's cephalomatomas. Cephalomatomas and shoulder dystocias. And those both occur in that second stage of labor where we have to use the vacuum-assisted deliveries. Now, the forceps deliveries are associated with higher risks of facial nerve palsies. Facial nerve palsies and third and fourth degree lacerations in the mother. Third and fourth degree lacerations in the mother. So that's second stage of labor for you. Now, the third stage of labor is the time of delivery of the infant to the delivery of the placenta. The placenta should be delivered within 30 minutes of the infant. Within 30 minutes of the infant, the placenta should be delivered. In order to prevent uterine inversion and hemorrhage, traction to the placenta should not be applied until there is evidence of separation from the uterine wall. Because what can happen is you can leak amniotic fluid, which is very gooey, very sticky, very viscous, and it can get into the veins and it can go and cause DVTs, strokes, PEs, embolisms. I mean, it's very bad. So traction to the placenta should not be applied until there is evidence of separation from that uterine wall. Now, the 3 signs that the placenta has separated from the uterine wall include, number 1, cord lengthening. A rush of blood, and number 3, fundal height evaluation. Alright, so cord lengthening, rush of blood, and elevation of fundal height. These are all in the retained placenta, and that is when the placenta does not deliver within 30 minutes. This often occurs with preterm deliveries or may be a sign of, you tell me, placental what? We talked about this in a couple prior lectures. Placenta accreta. Could be a sign of placenta accreta with a retained placenta, and that's when the placenta does not deliver within 30 minutes of the baby. This often occurs, like I said, in preemies. It should be removed with manual extraction or curettage. Now, synthetic oxytocin is identical to the oxytocin produced by the hypothalamus, and it is an inducer of labor. The mechanism of action is it's used to induce labor and control postpartum bleeding. So the mechanism of action is used to induce labor, and control postpartum hemorrhage. Control postpartum hemorrhage by inducing contraction of the uterine myometrium. That's how you would. I was sitting there thinking, how would you control postpartum hemorrhage? But what you're doing is you are controlling it by inducing contraction of the uterine myometrium through the use of the oxytocin. It also has anti-diuretic properties similar to antidiuretic hormone, so it can lead to a hyponatremia, seizures, and even death. It can also cause subarachnoid hemorrhage and uterine rupture. So oxytocin is extremely dangerous. Now, contraindications would be any fetal distress, premature delivery, and unfavorable fetal position. Unfavorable fetal position. Now, dinoproston, or the contraindications, it's not indicated for elective induction of labor. But dinoproston is a PGE2 analog. And a PGE2 analog that softens the cervix and induces uterine contractions to help with those abortions. So that is normal labor, or not help with the abortions, but help get the baby out. There we go. So let's talk about premature rupture of membranes, or also known as the water breaking. Premature rupture of membranes refers to rupture of membranes or water breaking prior to the onset of labor. Now, the rupture of membranes before 37 weeks is termed preterm rupture of membranes. Preterm rupture of membranes. Okay, now preterm premature rupture of membranes, which is PPROM. So preterm premature rupture of membranes can be particularly difficult to manage. The risk factors that induce PROM include ascending infection and smoking. Ascending infection and smoking. Now, the diagnosis is a woman will present with a clear fluid leaking from the vagina. clear fluid leaking from the vagina. Now, urine and physiological vaginal discharge must be ruled out. So by visualizing pooling of fluid in the vagina within the speculum exam, a positive nitrazine test, which is where amniotic fluid will turn the pH paper blue because it is alkaline, but so is bacterial vaginosis. So then you do a positive fern test, which shows amniotic fluid on a slide will look like a fern when placed under a microscope, but so does cervical mucus. So if the above tests are equivocal, an ultrasound can be performed. New oligohydramnios indicates rupture of membranes. Okay, so that's how that works. The treatment in treating premature ruptured membranes, the risk of chorioamnionitis must be balanced with the risk of prematurity. Now, if it's greater than 36 weeks, labor is induced. If it's 32 to 36 weeks, management is more controversial and many tests for fetal lung maturity and delivery when mature. So basically, delivery when the surfactant and phosphatidylglycerol ratio is there. Now, if you're below 32 weeks, you do bed rest, ampicillin, and corticosteroids. Now, why would we be using corticosteroids? Well, like dexamethasone or whatever, wouldn't that be stressful? Wouldn't that help the baby's stress response? Parasympathetic action kick out, produce more mucus, or the sympathetic action kick out, whichever one produce more mucus in the trachea, esophagus, right there. There you go, right? And then they start making surfactants. So that would make perfect sense to give them corticosteroids. Why not? Now, chorioamnionitis presents with it presents with ROM, maternal fever, and uterine tenderness in the absence of other known sources of fever, such as a URI or a UTI. So, if a pregnant woman has a fever, but she's had no UTI, URI, anything like that, but she has uterine tenderness, start thinking chorioamnionitis. You suspect chorioamnionitis should be treated with, let me write down the treatment for it here. Suspected chorioamnionitis should be treated with ampicillin, plus gentamicin, plus clindamycin. So right there you go. Ampicillin, gentamicin, and clindamycin is what you treat chorioamnionitis with if you have suspected that. All right, so that's premature rupture of membranes. So moving right along, that's what you need to know with the water breaking. I know that's a lot for each one of these, but pay attention to them and we'll get through these. So preterm labor. Premature infants are at an increased risk for the ARDS, man. The ARDS, intraventricular hemorrhage, sepsis, and necrotizing enterocolitis. Absolutely, but the big one too, remember, is the ARDS. So risk factors. The etiology of the preterm labor is unknown, but many risk factors have been identified. So the risk factors include prior preterm labor, preterm rupture of membranes, so PROM, chorioamnionitis, multiple gestations, uterine anomalies, placental abruption, preeclampsia, low socioeconomic status. I mean, they're kind of at a loss, but those are a lot of risk factors there. So labor before 37 weeks is termed what? Preterm labor, right? Preterm labor is less than 37 weeks, you're having preterm labor. Now, the diagnosis, preterm labor is diagnosed in a woman with contractions and cervical change prior to 37 weeks. This is different from cervical insufficiency, or dilation occurs without contractions. So make sure you get that. Cervical insufficiency is where dilation occurs without contractions. Now, tocolytics can be given to postpone delivery until steroid treatments take effect. The mechanism of magnesium sulfate, is not fully understood, but it is thought to compete with intracellular calcium and therefore with the reduction in uterine tone and contractility, but that's a bunch of crap. What happens is magnesium has a greater driving force than sodium, so it blocks it from depolarizing the cell, and that's why you get a reduction in uterine tone and contractility. Ritrodine and terbutaline are beta-adrenergic agonists used to delay labor. Their side effects is their non-specific beta-1 activation, so you're going to get tachycardia, nervousness, tremors, headaches, hyperglycemia, hypokalemia, and even rarely you can get pulmonary edema from that, believe it or not. But calcium channel blockers cause uterine smooth muscle relaxation and hence delay labor. Now, nifedipine is the preferred drug of this class due to its relative safety. Many tocolytics have only been shown to halt delivery for 48 hours. This is enough time to treat with glucocorticoid betamethasone to reduce the ARDS, so it is administered prior to 34 weeks. Administered prior to 34 weeks. Now, contraindications to tocolytics may include chorioamnionitis, placental abruption, and non-reassuring fetal heart tones. Alright, that's preterm labor for you. So, a prolapsed umbilical cord. How do we manage this sucker? Well, you do an immediate C-section. That's how you manage a prolapsed umbilical cord. You do an immediate cesarean section. you do not ever, do not try to put the cord back in the uterus. A prolapsed umbilical cord presents with several variable decelerations. Several or severe variable decelerations. I apologize. In an overt or complete prolapse, the umbilical cord protrudes into the vagina and is visible on exam. Now, umbilical cord prolapse is an obstetrical emergency. Risk factors include rupture of membranes with the fetus at a -2 station, polyhydramnios, and malpresentation. Example would be a footling breech. In an overt prolapse, the umbilical cord delivers before the fetus. In an overt uterus, or overt prolapsed umbilical cord. Wow, totally messed that up. Overt prolapsed umbilical cord. It delivers before the fetus. Now, in an occult prolapse, the cord delivers alongside the fetus. How about that? So that's overt prolapsed umbilical cord and an occult prolapsed umbilical cord. If the umbilical cord is compressed during labor, fetal oxygenation can be compromised and result in fetal demise or fetal death. So that takes us into our last topic, which is shoulder dystocia. The shoulder dystocia occurs when the infant's head delivers, but not the shoulders and the rest of the body. Now, the diagnosis is made in the second stage of labor. The second stage of labor is when the diagnosis is going to be made when the head has been delivered, but the delivery of the shoulders is delayed. Shoulder delivery delayed. Now, the anterior shoulder of the fetus is typically impacted behind the mother's pubic symphysis. So it's the anterior shoulder. In case you're asked a question about that on the boards. It's the anterior shoulder of the fetus that's getting trapped behind the mother's pubic symphysis. Now, let's talk about some risk factors. Some risk factors include maternal diabetes, so diabetes mellitus, obesity, and post-term pregnancies. And anything that leads to macrosomia. Anything that leads to macrosomia is a risk factor for shoulder dystocia. So complications include clavicle and humerus fractures, Erb's palsy. They like to go for this one on the boards. Erb's palsy, phrenic nerve palsy, hypoxic brain injury, and death. Now, so how do we manage shoulder dystocia? Management of shoulder dystocia requires an experienced team and includes the following maneuvers. The McRoberts maneuver. The McRoberts maneuver, which is a maternal thigh flexion. You also have to have the Woods corkscrew maneuver. The Woods corkscrew maneuver, where you have rotation of the infant to dislodge the shoulder. Then you have delivery of the posterior arm. Delivery of the posterior arm. Now, if these maneuvers do not work, the fetal clavicle may be fractured to ease delivery, or something called a Zalvalini maneuver. A Zalvalini maneuver. Might want to pay attention to that. Boards probably ask you something like that. A Zalvalini maneuver. The infant's head is pushed back into the uterus, which is performed in preparation for a C-section. That's called a Valini maneuver. Okay? So if the McRobertson's maneuver and the Woods corkscrew maneuver and delivery of the posterior arm do not work, then you have two options here. You can either fracture the fetal clavicle to ease the delivery, or you can do the Zellavini maneuver, where you push the infant's head back into the uterus to perform as prepared for a C-section. So that is shoulder dystocia for you, and pretty much everything you need to know about labor. Alrighty.